Welcome, this is Pancreatitis Imaging. So here are the things we're going to cover. What is pancreatitis and why we get it, how we image it, complications, how we report it, and what they do about it. There's a lot of great literature out there. Here are a few of the articles that I'll be referencing here in this lecture. A lot of the images in this lecture are pulled from these articles, or the images may be from my private collection. So let's talk about some causes of pancreatitis. Alcohol use is number one. This leads to intracellular accumulation of enzymes which are released and activated before they're supposed to be. Gallstones is the number two cause. Hypertriglyceridemia is an up-and-comer cause. We have a lot of fatty liver in this country, and hypertriglyceridemia is certainly a cause that needs to be evaluated when we're working these patients up. Other causes are pancreatic divisum, which we'll talk about. There are certain medications that can cause it. Having some surgeries or procedures, especially ERCP, can lead to acute pancreatitis. Hypercalcemia. Infectious diseases can cause it, such as Ascaris, cytomegalovirus, EBV, and Salmonella. Autoimmune causes of pancreatitis, which we'll talk about. Toxins and chemicals, such as insecticides and venom, can cause it. Scorpion stings, you may remember from medical school. There's a hereditary pancreatitis, which is usually seen in younger patients. And of course, tumors can cause it. So let's talk briefly about the Atlanta classification. It was originally created in 1992. It was revised in 2012. And it was created to describe the clinical severity of the disease and to set a standardized nomenclature to describe the complications, which would in turn set treatment plans. Two of the following are needed to diagnose pancreatitis. They need to have the characteristic abdominal pain, and they need an amylase or lipase 3 times the upper limits of normal. And now they've used imaging findings as a third choice in case the other two are equivocal. If we have classic imaging findings of pancreatitis, they'll go ahead and treat that patient as pancreatitis. So there are two pancreatitis phases. The early phase occurs in the first week after onset of pain, and it's characterized by a systemic inflammatory response, which can lead to organ failure. Late phase is described as 1 week later. It can last for months, and it's characterized by the persistence of organ failure or development of complications. When they talk about the severity of pancreatitis, they divide it into mild, which occurs in the majority of patients and has no organ failure or other complications. Moderately severe is the second, and it's characterized by transient organ failure that resolves within 48 hours, or local complications or systemic complications that do not result in organ failure. And the third is severe, which is defined by persistent organ failure lasting longer than 48 hours and carries a mortality rate as high as 50%. So let's talk about the types of acute pancreatitis. Interstitial edematous pancreatitis is the most common. It encompasses 90 to 95% of all cases. Here, the gland will enhance completely without areas of necrosis, and they may or may not have associated fluid collections. Necrotizing pancreatitis comprises 5 to 10% of cases. They'll have variable areas of necrosis, which will show as decreased enhancement on contrast scans. There are 3 subtypes. The combined pancreatic and peripancreatic necrosis is by far the most common. It's 75% of cases. Peripancreatic necrosis is the second most common at 20% of cases. And parenchymal necrosis only, when it only affects the pancreas itself, is only 5% of cases. Mortality is high for necrotizing pancreatitis, up to 17%, and if it becomes super infected, it can be as high as 30%. So do we need imaging for pancreatitis? If you look at the ACR appropriateness criteria, they break it down into 5 variants. Variant 1 is suspected acute pancreatitis, first-time presentation with classic symptoms. And the appropriate test to order in the first presentation is an ultrasound, and that's because we want to rule out gallstones as a cause. The second variant is suspected acute pancreatitis with some atypical signs. So those other Atlanta criteria are maybe equivocal, not really sure clinically what's going on. Do we need imaging? The ACR appropriateness criteria says, yeah, let's go ahead and do a CT abdomen pelvis with IV contrast. You can also do an MRI. Most of these are going to present through the emergency department, and so most people don't start with an MRI. But CT abdomen and pelvis with IV contrast is what's recommended. The third variant is acute pancreatitis, but now we're talking about a patient that's critically ill. So they're going through a systemic inflammatory response. They have severe clinical scores. Do we need imaging? Well, the ACR says CT abdomen pelvis with IV contrast or MRI without and with contrast are both appropriate. Variant 4, again, acute pancreatitis. We have severe clinical scores, leukocytosis and fever, and now we're looking at 7 to 21 days out. And again, CT abdomen pelvis with IV contrast or MRI are both considered appropriate. And then variant 5 is known necrotizing pancreatitis, significant deterioration in clinical status, and do we need imaging? Now we're talking about a CT abdomen pelvis with IV contrast. These are people usually in the ICU. They may be intubated at this point, multi-organ failure. It's a little bit harder to get MRIs on them, and CT is great for pancreatitis imaging, and so the ACR says a CT abdomen pelvis with IV contrast is appropriate. So what kind of CT do we need? Well, the ACR appropriateness criteria does a great job at detailing the types of CTs that we would need to get. And so here I've pulled a little snippet out of variant 2, and it says, given the limitations of early CT with or without contrast for stratification of disease, performing both a without and a with does not add additional information, and therefore just a CT abdomen pelvis with IV contrast is recommended. Again, here's variant 3, same statement. No need to do a with and without contrast, just do a CT abdomen pelvis with IV contrast. Now, once we get to variant 5, known necrotizing pancreatitis, this is that very sick patient, they actually do say that doing a non-contrast CT first might help if we're worried about detection of hemorrhage. So it can be helpful to get a with and without at that point, but otherwise, if they don't have any clinical concern for hemorrhage, you really don't need to do a non-contrast phase first. So here's a quick summary slide. Variant 1, we're going to start with ultrasound to rule out gallstones as a cause. Variant 2, 3, and 4, you could do CT with IV contrast or MRI with IV contrast. Variant 5, again, really just CT with IV contrast is going to be the best way to go. Variant 6, which I didn't mention, that's for chronic findings, and for that one you can do a CT or MRI with contrast. So here are a couple images of interstitial edematous pancreatitis. You can see that there's some fat stranding around the pancreas. In this image on the left, you can see some focal edema there around the head. In the second image on the right, you can see a lot of fat stranding in the lesser sac and between the pancreas and the liver, but we do have enhancement of the pancreatic parenchyma. Here are a couple images of necrotizing pancreatitis. The image on the left shows a star on what is enhancing pancreatic parenchyma, but the white arrows are showing parts of the pancreas that show no enhancement. Those are the necrotizing portions. And then again, in the second image on the right, you can see that the tail is enhancing and the head is enhancing, but there is a portion in the region of the neck that has no enhancement. So what if you can't tell if it's an interstitial edematous or if it's a necrotizing pancreatitis? Sometimes it can be hard. And what if they order the CT without IV contrast and you can't judge the amount of enhancement in the parenchyma? Well, you just take your best guess. Sometimes the parenchyma is so edematous that it can look like it's not enhancing. In these cases, it's really hard to say for sure. So you just take your best guess. So let's talk about types of peripancreatic collections. An acute peripancreatic collection is present in the setting of an interstitial edematous pancreatitis. It's simple appearing and turns into a pseudocyst after about 4 weeks. An acute necrotic collection is present in the setting of necrotizing pancreatitis. It's definitely more heterogeneous. It's a more dirty collection, often contains fat, and this will turn into what we call a walled-off necrosis. Here's a nice little chart of the fluid collection timeline. So if the patient has interstitial edematous pancreatitis, then the peripancreatic collection that they have in the first 4 weeks is called an acute peripancreatic collection. After 4 weeks, we call that a pseudocyst. If the patient has necrotizing pancreatitis, the peripancreatic collection is called an acute necrotic collection in the first 4 weeks, and then after 4 weeks, we call it walled-off necrosis. So these peripancreatic collections can really go anywhere. It's most common in the abdomen and pelvis, but they can be even in the thorax. And so the first image, the one on the left, shows a collection in the left lower quadrant. It's very common for these pseudocysts and areas of walled-off necrosis to travel south down to the pelvis. It really likes the anterior and posterior pararenal spaces. They can be found deep in the dependent portion of the pelvis. And then the second image, the one on the right, shows fluid that's tracking along the right side of the esophagus, and then you can see a left pleural effusion. And so these are pretty common findings. So can imaging help determine the cause? Sometimes, yeah. So we know that we do an ultrasound in variant 1 to look for gallstones, but on CT there are a few signs that can help us guide them into the right direction as the cause. So in the case of autoimmune pancreatitis, the pancreas will look diffusely enlarged. This is what we call the sausage pancreas, and it can have a peripheral rind of hypoattenuation, and sometimes you'll see a tiny duct. Groove pancreatitis is inflammation between the pancreatic head and the duodenum, and in this case, you may have small cystic lesions along the medial duodenal wall. I've never seen that in real life, but that's what they say. In hereditary pancreatitis, usually these are a young age of onset and they have a family history. Ectopic or heterotopic pancreatic tissue can become inflamed. And for this, you're going to look for centrally umbilicated nodules in the gastric mucosa, usually in the prepyloric region, or you can have these in the duodenum. Those are foci of ectopic pancreatic tissue. And they'll enhance just like the pancreas in the other phases. Cystic fibrosis, you'll have complete fatty replacement of the pancreas, but it can become inflamed and get fat stranding within that fat-filled area. Ascaris induced, I've never seen this in real life, but you're going to look for an echogenic tubular structure in the bile duct. Pancreatic divisum, very common. MRI and MRCP is optimal to look for this, and what you're looking for is a lack of communication between the primary and secondary pancreatic ducts. And then tumor, of course, can cause it. Usually these are really hard to see. They can certainly be occult. What you're looking for is an abrupt caliber change of the main pancreatic duct with upstream atrophy of the pancreatic parenchyma. So this is autoimmune pancreatitis. I mentioned the sausage pancreas. The top image shows that there's no tapering of the tail towards the splenic hilum. There's sort of an abrupt cutoff. And it's sort of sausage shaped. The bottom image shows the hypodense rim around the pancreas. And what this is the manifestation of IgG4 related sclerosing disease. It can also affect the bile ducts, gallbladder, kidneys, thyroid, salivary glands, lymph nodes, and prostate. This leads to lymphocytic infiltration, which then leads to repeated inflammation and fibrosis and eventual organ dysfunction. And it responds pretty well to steroids. So sometimes if the patient presents with this particular type of pancreatitis, they may not know this is IgG4 related, and so these findings can help you, help the team figure out which road to travel down when they're looking for a cause. This is groove pancreatitis. This image is showing the inflammation between the duodenum and the pancreatic head. They've illustrated a few of those small cysts that I mentioned. And here are a couple of images. Really, it's just pancreatic inflammation at the head. In this bottom image, you can see a little bit of focal edema there layering anterior to the duodenum. Here's an image of ectopic pancreatic tissue. The large white arrow is pointing to the ectopic tissue, and you can see that it looks just like the pancreas, and it's focally inflamed. Here's a case of cystic fibrosis. There's a little bit of residual pancreatic parenchyma here. This is a young patient. It's not completely fatty replaced, but you can see all the fat stranding around the pancreas on these two images. Here's an image of the ascaris. You can see it within the bile duct on these MRCP images. So let's review pancreatic divisum. This is certainly a known cause of acute pancreatitis, common cause of chronic pancreatitis. And so the pancreas has a major duct and a minor duct. The major duct is supposed to do pretty much all the heavy lifting of the drainage of the enzymes. And so in the first image on the upper left, you can see that the main pancreatic duct is coming from the tail, heading towards the head, but it doesn't connect to the ventral bud. And so what's happening is all the drainage is going through the secondary duct into the minor papilla. And so the red arrows indicate the minor papilla. There is a duct within the ventral bud, but it's not really connected to the rest of the pancreas. It is draining into the major papilla, which is where it's supposed to be going, and the major papilla are indicated by the green arrows. Sometimes they are connected and there's equal drainage between the two, the minor and the major ducts. However, if the major duct is not carrying the heavy work here, then that can lead to pancreatitis. And so I've got a couple images here. This is a CT axial image, and the red arrow is pointing to the pancreatic duct that's draining into the minor papilla, whereas the green arrow is pointing to the common bile duct, which is where the pancreatic duct is supposed to be going into the major papilla. And then I have an MRCP image where you can see a nice pancreatic duct coming from the tail, swooping around the head, and it's draining into the minor papilla of the duodenum and not following the course of the common bile duct, which is draining into the major papilla. And we can't forget tumor as a cause of pancreatitis. And these can be very subtle. And so what you're looking for is an ill-defined area of hypoattenuation, which can be difficult to tell between this and focal edema. But what you're looking for is upstream atrophy. The tail is going to be smaller than the affected area. The duct is going to be dilated upstream, so that you can see in these two images that the pancreatic duct is dilated. And in the third image on the far right, you really don't see a definitive mass. You see what looks like pancreatitis, but we're not seeing the atrophy yet or the pancreatic duct dilation. And so in this case, you would call this acute pancreatitis, and they would have to just do further workup to exclude tumor. So in the first 4 weeks, we're going to either get an acute peripancreatic collection if they have interstitial edematous pancreatitis, or we're going to get an acute necrotic collection if they have necrotizing. And so here are a couple examples. An acute peripancreatic collection is going to be more simple. It's going to be more water density, and you can see it around the pancreatic head and tail here. And an acute necrotic collection, it's going to be very dirty. It's going to start digesting the peripancreatic fat, and so you're going to have a lot of debris and heterogeneity of that collection. So after 4 weeks, if we had interstitial edematous pancreatitis, we're going to get a pseudocyst. Again, very simple water density like you see in this first image, very well circumscribed. And then walled-off necrosis, again, will be more heterogeneous. It's going to have more densities in it, and it's going to look dirtier. So here are some of the complications of pancreatitis. Pancreatic exocrine dysfunction is common. We'll talk a little bit about that. Vascular complications, which include venous occlusion and pseudoaneurysm. Early satiety, which is usually due to a large pseudocyst. Gastric outlet obstruction, not common, but it can happen. And cancer. So people with chronic obstructive pancreatitis carry the highest risk, which also increases with age. Now we have to think about compounding variables. A lot of these patients, if they have a history of alcohol abuse, they also have an increased risk of smoking, and all of those things are going to factor into their increased risk of getting cancer. So let's talk about the vascular complications. Arterial pseudoaneurysm, the most common affected artery is the splenic artery, followed by the gastroduodenal artery, the pancreaticoduodenal artery, hepatic artery, and left gastric artery. These are, of course, higher risk in necrotizing pancreatitis, and they carry a risk of rupture. Venous thrombosis is not uncommon. The splenic vein is the most common. 7% of all pancreatitis patients will get it. Do they anticoagulate? Well, sometimes they do. It depends on the patient's risk factors and if other venous thrombosis is present, such as in the main portal vein or the superior mesenteric vein. So anticoagulation can reduce portal hypertension, which can reduce variceal formation and can reduce the patient's risk of a variceal bleed. But of course, giving anticoagulation, there's an inherent risk of bleeding when you're on it. So current studies show that there's no significant outcome change between patients that are treated and those that aren't. It's really up to the clinician. We do know that 20% of patients, if we leave it alone, the splenic vein will recanalize. And if we give anticoagulation, that does go up to 36%. And then varices will form in 57% of patients if we don't anticoagulate, if we leave them alone, and 51% will develop varices if it's given. So they're not significant changes. And then risk of hemorrhage. Up to 5% of patients will experience hemorrhage. Of course, that number is higher the worse the pancreatitis is, especially if it's necrotizing. Mortality rate is high, up to 52%. The most common vessel is the splenic artery, followed by the portal vein, the splenic vein, and other smaller peripancreatic vessels. So you figured out your patient has acute pancreatitis. What are you going to do with that? Well, a lot of groups are advocating for structured reporting for this. And that's because if we give the gastroenterologist as many details about this as possible, they're going to manage that patient better. And so what they've done is they've divided into 3 categories. So for descriptions of the pancreas, you can see here, it's a beautiful article, that they've talked about pancreatic enlargement, enhancement, necrosis. They've divided the necrosis into percentages. The site of necrosis, if there's any intrapancreatic collection, disconnected duct, which we'll talk about, describing the pancreatic duct, if there's any mass, and if we can tell if divisum is present. Then it's divided into peripancreatic collections. So the type of collection, the location, is there gas, is there hemorrhage, is there ascites? And then talking about upper abdominal vasculature. This is all very important for management and complications. And so they've talked about thrombosis of the regional veins, are there perigastric varices, or any pseudoaneurysm of the regional arteries. So again, here are the descriptors you should be using for pancreatitis. You don't have to use a structured report format, but all of these things are very important for the clinicians to know. This is what my personal template looks like in my PowerScribe. It takes all of the descriptors that you saw in the previous slide, and I've turned them into pick lists. We don't have any sort of reporting software like the mammographers use where you can just click and the report is created for you. We have to do the clicking manually, but it's not too bad. Everything is here so that you don't really forget to mention anything that's important. I'll talk very briefly about chronic pancreatitis. It's seen with repeated bouts of acute pancreatitis. The pancreas becomes fibrotic and loses acinar cells. Imaging findings include calcifications and pancreatic duct changes. And the Cambridge classification is based on changes of the main pancreatic duct and its side branches. And of course, we have a great article out there from the Adult Chronic Pancreatitis Working Group. And I won't go through everything on this chart, but the main idea is we want to describe the main pancreatic duct, its branches, the sizes and the contours of these, pancreatic parenchyma enhancement in arterial and venous phases, and if we're doing an MRI, it's T1 intensity. We want to describe the pancreatic calcifications, talk about intraductal calculi, and if we're doing an MRI with secretin, they talk about the duodenal filling after a secretin injection. So I want to talk for a minute about MRCP secretin exams. Not a lot of places are doing this. I have a little bit of experience with this. So I wanted to sort of touch on this in case you're looking at some of these articles and guidelines and you're thinking, what in the world is she talking about? So what this does is it specifically evaluates the pancreatic duct and the exocrine reserve. And so what happens is you do a regular MRCP exam, and then this will add about 15 minutes to your exam. It also uses heavily weighted T2 sequences, So it's like an additional MRCP sequence. And so some places will give fluid suppression, some sort of PO contrast before the exam, which in my experience we use pineapple juice, but you could use pineapple or blueberry juice. And all this does is suppress the signal in the duodenum so that you don't have a bright T2 signal in the duodenum that can interfere with your results. So we inject about 16 micrograms of secretin in an IV, followed by a 20 cc saline flush. Some places give glucagon to reduce peristalsis so you don't have artifact or any sort of changes in your images during your sequence. Some patients can experience nausea, abdominal pain, and or flushing. It's very rare, 0.5% of patients will have that. And what happens is this increases the intraductal pressure within the pancreatic duct, and it starts to affect it within 1 minute, and you get near complete relaxation at 5 minutes. So it's very fast acting. And what this does is cause an increased fluid signal in the duct, which will then travel into the duodenum. So once you have the correct angle of the pancreatic biliary system all lined up, you take rapid snapshots for 10 to 15 minutes. These can be obtained up to 45 minutes. I've never seen one that long. Usually it just takes a few minutes to get the results. And so what happens is the pancreatic duct and its side branches will normally increase in diameter after injection. So you're going to report the before and after diameters. And then the volume of fluid in the duodenum should increase if you have normal exocrine function. And so we can grade these. So grade 0 is no increased fluid, so that's not good. Grade 1 is increased fluid in just the bulb, so the little bit of function, not great. Grade 2 is proximal to the third segment, and then grade 3 is the best, where you have increased fluid in the distal third segment or beyond. That would mean there's a normal exam. So these are images of what a normal MRCP secretin exam would be. And so in the first image on the left, you can see the common bile duct and the pancreatic duct coming down. Looks pretty normal. There's a little bit of signal in the duodenum. That turns out to be a diverticulum. It's not within the lumen itself. On the second image, after the secretin has been given, you can see that the pancreatic duct diameter has increased, so you're going to report that. And now we have T2 signal within the duodenum, and it extends all the way to the fourth portion of the duodenum. And again, you can see that diverticulum there. So this is normal. Here's a secretin exam in the patient with pancreatic divisum. And you can see the arrow in the first image is pointing to the main pancreatic duct that's draining into the minor papilla and not the major papilla with the common bile duct. And then after secretin, you can see that the duct increases in diameter a little bit, and you can see it draining into the minor papilla. And then you can see there's definitely an increased signal within the duodenum. There was a little bit ahead of time, but it definitely increased after we gave secretin. So even though they have pancreatic divisum, it looks like it's functioning normally. And then here is a case with exocrine dysfunction. So in the first image, the duct is a little dilated, it's ectatic, not a lot of signal in the duodenum. Once we gave secretin, the duct remains irregular. You don't really see it too well. You do, however, see that there's a stricture in the most distal portion of the duct, just proximal to the ampulla, and there's not really an increased signal in the duodenum. So this confirms that there is a stricture present, and this is probably the cause of their chronic pancreatitis. Pancreatitis complications. Infection. Up to a third of necrotizing pancreatitis will become infected. Duct disruption, which I'll talk about. Vascular complications, which I briefly touched on, which include regional venous thrombosis, pseudoaneurysm formation. Up to 10% of these patients will get a pseudoaneurysm in one of the regional arteries, which also can lead to active bleeding, and fistula formation. Disconnected pancreatic duct syndrome. This occurs in up to a third of patients with necrotizing pancreatitis, particularly when there's necrosis larger than 2 centimeters. It's often overlooked at imaging. It causes an acute collection or recurrent collections if it's missed. And what you're looking for is a discrete intrapancreatic collection along the expected location of the duct. This is usually found in the neck or the body with viable enhancing upstream pancreatic tail. And you're going to look for an upstream duct that is oriented perpendicular to the collection or directly communicates with it. And I'll show you an image. So this is what it looks like. We've got a well-circumscribed fluid collection in the region of the neck. We've got an atrophic upstream gland with dilation of the pancreatic duct. There's a little bit of enhancement of that parenchyma. And on the drawing, you can see that there's a sharp angle between where the main pancreatic duct lies and the wall of this collection. That is going to clue you in that this is a disrupted duct. Another complication is called hemosuccus pancreaticus. This is defined as bleeding from the ampulla via the pancreatic duct. It usually originates from the splenic artery, gastric artery, or pancreaticoduodenal artery. Commonly, it's in the setting of a pseudoaneurysm, and it's much more common in men. So what do we do with peripancreatic air? Is it infected pancreatic necrosis? Is it a fistula? Well, it can be very hard to tell. Sometimes air will appear, and we'll do a contrasted CT with oral contrast, and we never can define a fistula. Sometimes it is infected pancreatic necrosis. Of course, in the second image, there's a pretty large fluid air level in that, and so for that case, I would be more concerned about a duodenal or gastric fistula there. So PO contrast would probably help in that situation. But again, sometimes we just can't tell. So this is a chart of the management of necrotizing pancreatitis. I won't go through all of this, but you can see it's pretty complex, and there are a lot of options that gastroenterologists have for treating these patients with necrotizing pancreatitis. We'll go through a few. So some of the treatments. Cyst gastrostomy tube placement is pretty common, and so there's a couple of ways to do that. Double pigtail stents are usually used in the setting of a pseudocyst, a more simple collection, or a single large metallic stent. That's more seen in walled-off necrosis. Necrosectomy is when they do a mechanical debridement via an endoscope. Those are usually in more severe cases. And pancreatic duct stenting facilitates drainage, which helps open strictures and cover any leaks, and these things can migrate. So this type of cyst gastrostomy tube is placed in a pretty simple pseudocyst. So we've got a nice clear collection in the lesser sac here. This one would be very amenable to the plastic stent. Usually they put 2 in, and so the gastroenterologist will go in, they'll puncture a hole in the gastric wall, and they run these catheters in between the pseudocyst and the stomach, and all that fluid will just be released into the stomach. They leave these in for a month or 2, and then they take them out. Unfortunately, when we have walled-off necrosis, the contents of the fluid is too thick. It's going to have big cellular components and debris in it, and the thin little plastic stents are not going to be good enough. They're going to get clogged, and so they have to put something larger in, such as this metallic stent here. Here are a few types of those metallic stents that they use. Here is a pancreatic duct stent, pretty typical appearance. Here's what it looks like on a CT. And then sometimes these things will slip out. They go right into the duodenum and the rest of the GI tract. And then sometimes you see them on the KUB, like this example, where it's down in the colon. It's okay. They'll just excrete these. So with a necrosectomy, this is done generally in patients with more severe disease. And this is removal of necrotic tissue and fluid collection drainage. This can be done with an endoscope, a laparoscope, or an open surgical procedure. Every once in a while, IR will put a percutaneous drain in one of these things, but generally the GI guys like to go in and do these themselves. Here are my references. Thank you guys very much. Let me know if you have any questions.